Hi, this is Eric Dein with Room Now at day 2 of ACR Convergence conference here in Philadelphia. I'm here with Dr. Lauren Smith from Georgetown Rheumatology. And tell me about your oral presentation you gave.
Yes, so yesterday I gave a presentation looking at the examination of treatment response with mycophenolate Mofetil in black versus white patients with scleroderma. Specifically, we looked at patients with ILD and cutaneous disease, in particular the diffuse cutaneous subtype. And the goal of our study was to evaluate, was there a significant difference in treatment response? In particular because, unfortunately, black patients have been known to have more aggressive disease phenotype as well as more diffuse cutaneous disease. So we looked at patients over a 5-year period, and we calculated their change in MRSS or change in FVC percent predicted over that 5-year time period at 6 and 12-month intervals. And what we were able to find is that over time, the annualized rate of decline in FVC for black patients was not as significant as white patients. It was fairly stable, actually, and the white patients had more of a decline. But in looking at the baseline FVC, that number was much lower in black patients at 66% compared to 81% in our cohort. And this data is from Johns Hopkins, even though I'm currently at Georgetown, just to clarify. And essentially, we found that when looking at subgroup analysis in terms of when MMF was started versus how many indications they might have been using MMF, as well as autoantibody and scleroderma subtype, this trend of black patients having a more stable FVC compared to white patients was pretty consistent. And then we also looked at patients when we restricted the analysis to patients with a baseline FVC of 70%, and even in that case, it ended up being qualitatively pretty similar, though it wasn't as statistically significant as the other subgroups. And similarly, in looking at cutaneous disease, in terms of the modified Rodnan skin score, we saw that white patients actually had, both groups had a significant decline in their MRSS each year over time. However, this decline was actually more substantial in white patients compared to black patients. And we're still trying to figure out exactly why that was the case. Part of it is maybe potentially that more white patients have an RNA polymerase III autoantibody subtype as opposed to the SCL70, but to be determined.
So is there a delay in diagnosis for African American patients in order of getting into the group, or why do they come in? Is it all phenotype?
Yes, so that's actually a really good point. So when looking at our data, the age at diagnosis or age at first non-Raynaud symptom was actually statistically different between the groups, with black patients being having their first symptom around age 42 and white patients having their first symptom around age 49. However, by the time they presented to clinic, it was roughly about 3 years after that symptom started. So that wasn't too different. However, their baseline FVC scores were actually pretty statistically significant. So we're thinking that black patients actually have just a worse or more aggressive disease, and so they need to be diagnosed sooner and treated more aggressively. But it's not that they necessarily have an inadequate response to disease, or inadequate response to treatment therapies, more so just a more aggressive baseline. And the reasons for that, we're still trying to figure out. Some of the theories are, is there changes in, or differences in social determinants of health? Are there different other genetic predisposition or epigenetics that may be playing a role? And so more work to be done.
It sounds like a lot more possible investigation from there.
Yes.
Thank you so much for your time. Enjoy the rest of the conference.
Excellent.
And anything else, tune in to Room Now for more coverage throughout Convergence.